is a big pleasure for all of us at the IAGES family to meet all of you this evening for a very important event of IAGES, the IAGES Prime Time. IAGES Prime Time has been highlighting the legendary achievements and legendary work done by surgeons, both in the national and the international arena. So today we have two eminent personalities amidst us. One is Professor Michel Gagner from Montreal, and he is going to talk to us on minimally invasive endocrine surgery. And the next important personality is our own Professor Pradeep Chaubey sir, who has been with us all through the IAGES and who has been our mentor and who has been our guiding force for all the IAGES activities and who has been there always with us. So to interview them, we have two most known and popular persons of the IAGES, and another than Professor Subhash Khanna, who will be interacting with Dr. Michel Gagner, and later our own friend, colleague, Dr. Deep, who will be interacting with Professor Chaubey. So this is the plan for the day. Now I take privilege and pleasure in inviting Professor Subhash Khanna. Professor Subhash Khanna is a very popular figure in IAGES. For people who are attending out of IAGES, a brief introduction about Dr. Khanna. Dr. Khanna is the past trustee of the IAGES, and he had a very long and glorious academic career on teaching side. And now he has founded his own super specialty medical institute in Guwahati, and he is the pioneering robotic surgeon from that part of the country. And in fact, to put credit to him, he was the one to initiate minimally invasive workshops and endoscopy workshops, and he conceptualized the advanced gastrointestinal endoscopy course, and he was the first to do the FAGI course in Guwahati. And he's a quite committed academician, where he continues to train brilliant young surgeons to come into the field of laparoscopy and endoscopy together. Ladies and gentlemen, he also spearheaded the most important activity of the IAGES. The COVID relief program of the IAGES was spearheaded by our Khanna sir, and more so, the government of Assam entrusted him with the very big responsibility of handling more than 200 to 250 crores of rupees for distribution of the relief to the health sector. So he's a towering personality, and the most exciting thing I'm going to share with you is IAGES will be hosting the World Congress very soon, within a couple of years, and Khanna sir takes a very big responsibility in hosting the program for all of us. With that few words, now I would like to invite Professor Subhash Khanna sir to take over the day's proceeding. Khanna sir, over to you.
Thank you, Kanagavel. Thank you for that kind introduction. Good evening, Professor Michel. Good evening, Dr. Pradeep Chaubey, and good evening, everyone. My dear friends in IAGES, all surgical colleagues, and there are some invited guests also, ladies and gentlemen. This evening, I have the pleasant task of introducing one of the two legends we have today, and that the first legend to be introduced and who will be speaking to us today is Professor Michel Gagner. Professor Michel Gagner had a very illustrious career, and I consider him as a polymath, a man who knows many subjects. I shall be going through his short bio in few minutes, and let me introduce him. Professor Michel Gagner is a senior consultant at the Hopital du Sacre Coeur, Montreal, and is also the Chief of Surgery at the Westmount Square Surgical Center, Westmount. He was born in 1960 in Montreal, Quebec, Canada. Dr. Gagner obtained a diploma in sciences at the Seminar de Sherbrooke in Sherbrooke in 1978. So he got his diploma at a young age of 18, and his MD from the Faculté de Medicine de University de Sherbrooke in Canada in 1982. He did his surgical training at McGill University in Montreal from 1982 to 1988. During his residency, he completed 2 years of PhD program on human lipolysis in sepsis at the Royal Victoria Hospital, McGill University from 84 to 86. Dr. Gagner also completed fellowships in hepatic surgery at Hopital du Sacre in Paris, in France, and pancreatic surgery at Lahey Clinic Medical Center in Burlington at the Massachusetts from 89 to 90. Upon completion of his fellowship, he was recruited to the University of Medicine, Hopital du Montreal, where he was assistant professor of surgery from 1990 to 1995. He then spent several years at the Cleveland Clinic in Cleveland, where he founded the MIS Center in the year from 1995 to 1998. He was appointed the Franz Schizel Professor of Surgery and Director of MIS Center at the Mount Sinai School of Medicine in New York from 1998 to 2003. He later joined Weill Medical Center, Medical College of Cornell University, New York as Professor of Surgery and Chief of Section of Laparoscopic and Bariatric Surgery. He was until recently chair of the Department of Surgery at the Mount Sinai Medical Center, Miami, and professor of surgery at Florida International University, and is currently professor of surgery at the Montreal. Dr. Gagner is known for his contribution in the field of minimally invasive surgery, in particular the first description of laparoscopic adenectomy for Cushing syndrome and pheochromocytoma. That was way back in 1992. First description of laparoscopic pancreatectomy, distal and proximal in 1992. First description of endoscopic neck surgery with parathyroid in 1995. First transgastric cholecystectomy or notes in 1997, and first description of laparoscopic donor switch for obesity in 1999, and laparoscopic sleeve gastrectomy in 2000. More recently, was co-surgeon for the World Transatlantic Robotic Cholecystectomy that was done between New York and Strasbourg, France, and the only surgical article published in Nature in 2001. He has over 300 published journal articles, 40 book chapters, and 8 books on MIS. He has been visiting professor and operated in over 60 institutions in 48 countries. He has held prominent positions in more than 35 societies and organizations and has served on the board of 12 surgical journals. Dr. Gagner also has received a number of honorary memberships awards throughout his career. His most recent contributions focus on innovative upper digestive surgery, such as bariatric and endoluminal gastric procedures. That's, ladies and gentlemen, very brief of the huge amount of work done by Professor Michel. Ladies and gentlemen, a role model to be followed for all the young and all like us also for all the years to come. I request and I present before you, it's my pleasure to present before you Professor Michel Gagner for his talk. Professor Michel, please.
Thank you very much for this introduction. I'm very pleased with the invitation from the Indian friends and colleagues from the society. I think this is, as you know, I've been going and traveling over the years and enjoying my interaction with many colleagues present today, and I'm sure those that are also participating by the internet. So thank you very much for this invitation. So without any delay, I would like to share my screen and do this presentation because I have many slides. Many people know that I present too many slides, so I want to start right away. Let me share my screen. And this this should be full. So it's entitled Minimally Invasive Endocrine Surgery, 30 Years of Surgical Innovation, if you want. The first thing I would like to say is that a lot of those discoveries have been by serendipity, which is a modern accident in modern medicine. This was discussed in 2007 in the New England Journal of Medicine. And in medicine, it is thought that 30 to 50% of scientific discoveries are indeed accidental and not happening according to the protocol. So surgery, I think, in laparoscopic surgery is in the same way. The discovery often starts when a researcher finds a bug in their experiment, of course, and you have to realize that maybe something is happening. For example, penicillin was discovered by serendipity because a mold had contaminated the culture. Of course, X-rays was discovered by serendipity because of the heavy paper that was put around to protect the X-rays. Well, that made an impression on the paper. And of course, more recently, Viagra was discovered by serendipity, increasing blood flow somewhere else. And, that led to Nobel Prize in Physiology in 1998, interestingly. So we have to reformulate sometime our, thinking to look at the bugs in the experiment and find that sometimes this is a happy accident. And of course, serendipity is a word that is difficult to translate. Recently in French, we have had this word, and in Spanish only a few years ago, serendipity, interestingly, comes from in a letter sent by the Earl of Orford, talking about a book, The Princes of Serendip. And Serendip is apparently Sri Lanka word for Sri Lanka. It's a Persian word for Sri Lanka, and where apparently the tale of a lost camel, where the father is sending his 3 sons to look for a lost camel and a treasure, with indices along their journey. By serendipity, they discover the camel and the treasure. So I'm indebted to Professor Jacques Périssat from the University of Bordeaux, which had organized one of the very first World Congress of laparoscopic surgery, fantastic, with wine, and I believe in 1992, in the summer of 1992. But I had heard Professor Périssat in Toronto in 1989 during a World Congress of Surgery, presenting on laparoscopic cholecystectomy. And it's at that time that I believed that this would be the future of surgery for the next 30 years now. So laparoscopic adrenalectomy is the 4 topics I would like to cover. I started my career as a professor at the Hopital du Sacre of Montreal. This hospital is one of the first hospital in Canada. Was founded in 1642. It's in used to be in the old Montreal, and at one point was one of the largest hospitals in the British Commonwealth. The surgical history described that the first nephrectomy was performed by Sir William Hingston at the Hopital du Sacre in 1868, but we're not sure if there was an adrenal gland as part of this resection, so it could have been the first adrenalectomy in 1868. And Sir William Hingston became later, as a surgeon, the mayor of the city, and was confronted to several pandemics of cholera at the time, which was without any treatment, of course, but nice surgeon who had made discoveries at the Hopital du Sacre. And Hopital du Sacre is also famous for Paul Cartier, a vascular surgeon who had done the first world axillofem bypass and fem-fem bypass, and was the one who was doing open adrenalectomy at the time when I came on staff in 1990. And I proposed that we do laparoscopic adrenalectomy, and he said to me, "You have to show me how you do this in animals. And so we had established an animal lab and practiced laparoscopic adrenalectomy in pigs before 1992, make a video and show this to endocrinologists that it was probably possible to do this in humans. At the Bordeaux Congress, without knowing, Joe Peatland had presented a video on laparoscopic adrenalectomy. We had performed several cases, but of course did not had the opportunity to present an abstract on this. But Joe Peatland was among the first to do this in the United States with an anterior approach. We had we had submitted before. The presentation was in September, and this appeared in October, 1st of October, in the New England Journal of Medicine on laparoscopic adrenalectomy in Cushing syndrome and pheochromocytoma. So we had started to assemble a series at that time. We had done them before September 1992 and before Joe Peatland. I was unaware that in Japan, Higashihara and laparoscopic adrenalectomy in Japan. This was a report in Japanese from the University of Tokyo, from the urology, and this was in hyperaldosterone tumor. This is our press conference in 1992. You can see me on the extreme right, and Dr. Palm, for those who know, is the first person sitting there. We looked much younger 30 years ago, and this was of big interest. And my second fellow, Adrian Park, who became prominent also in the United States in the University of Maryland, had helped me published on laparoscopic adrenalectomy in the pig to teach surgeons, because it's one thing to do a procedure, you also have to teach it around the world how to do this. And we presented at American College of Surgeons 2 posters the following year, one on adrenal and the other one on double endoscopy, intraoperative ERCP for common bile duct stones was the problem of the hour at the time. And the president of the American Association of Endocrine Surgeons, Dr. Prince, was present, saw our poster and asked me to do a presentation at the American Association of Endocrine Surgery. I presented on 25 cases in 1993. And of course, many audience, American endocrine surgeons were present and asked me to come to their hospital to perform their first laparoscopic adrenalectomy at the time. And I performed the first adrenalectomy at Yale University, invited by Barbara Kinder, and went from one institution to the next to teach surgeons how to do this operation. I went to the Mayo Clinic and helped them perform their first laparoscopic adrenalectomy. At the time, John Van Heerden, who was the prominent, one of the most prominent endocrine surgeon, was not a believer of laparoadrenalectomy. He tried to convince me to do posterior approach by an open incision, but it never took off. I think it stopped this progression with laparoscopic adrenalectomy. And the same with Charles Poix, who died a few years ago, was the most prominent international endocrine surgeon from Lille, France, had invited me to do 2 cases in his hospital, and was then convinced that this was the way to go. And then we published at the American Surgical on the first 100 cases in 1997, so 5 years later. And this was the American Surgical is a very prominent association and published in the Annals of Surgery in 1997. This was the stamp of approval of a technique. If we look from 1992 to 2002, so 10 years period, you see the number of publication increasing year after year, such that 10 years after the first adrenalectomy, there were 617 publications, and we collected 2,250 cases. And you can see the indication is just like any open adrenalectomy, aldosterone, pheochromocytoma, Cushing. Most of the surgeons at the time used the lateral transabdominal, which was my technique of putting the patient on the side. And 20% were using at the time retroperitoneal. This is the way we describe it, putting the patient on the side, flexing the table, putting trocars in the subcostal area, mobilizing the inferior part of the spleen and all the spleen ligament posteriorly to open everything like a book. And the left adrenal was sitting behind the spleen, and then dissecting the adrenal, isolating the vein and clipping this end, making sure that you're not damaging any renal vessels. The right side is a mirror image if you want, subcostal trocars, 3 or 4 in the subcostal right. The difference here is that it's a mobilization of the triangular ligament of the liver and exposing the cava. Here's an exposure live of the cava with a large vein that would not take clips. In those circumstances, when the vascular stapler came, it made the operation safer in handling a vein from the right on the right side. And then extraction is done with a bag, so you're not seeding in case there is a malignant tumor. You're not seeding in the tract of extraction. Getting the tumor in total with the specimen for proper pathological identification. It made a stamp of approval with a very low mortality, very low morbidity. Complication within that morbidity was, number one, the bleeding. So you have to be very slow and careful. The reason for conversions, which are very low, was again because of bleeding or vessel injury. Now we progressed. When I was at the needle Cleveland Clinic, we progressed to do what we call needlescopic adrenalectomy, and that is the use of 2 millimeter or less instruments. And then the belly button was used for extraction, for clipping or observing, putting the laparoscope in the belly button, which is the, if you want, the precursor of a single incision laparoscopic surgery. And the needlescopic surgery started around that time, 94, 95. We started to have instrumentation, and we had experimented with needlescopic adrenalectomy, which was very nice cosmetically, and causing less pain and faster recovery. The hospital stay was reduced almost by 1 day using this. And then also we progressed. Instead of doing extraction from the belly button, we had extraction from natural orifice. That is from the stomach, making a small gastrotomy and taking the adrenal out from the mouth with a gastroscope, having just needlescopic instrumentation in the abdomen, or also vagina extraction. If I go to pancreas, we published in 1994, but our cases started before. I was a hepatobiliary surgeon doing, hundreds of cases of Whipple open. So I had the anatomy really in my head and started by using laparoscopy to make sure that the tumor was resectable. We were doing all the maneuvers, including looking behind the neck of the pancreas over the portal vein to see if there was resectable indeed. When we did those maneuvers, we were getting close to a resection. But the stapler came later, available in Canada more like the end of 1991, beginning of 1992. It was a short stapler, 30 millimeters long, and not the best, I can tell you. But it permitted us to do GI surgery. And so there are cases we did hand-assisted, but most of the cases we did completely laparoscopy. This is the first use of harmonic, because the first cases we did not have any harmonic technology. We had to transect the pancreas with the hook, for example, or the uncinate process with the hook. And so it was very cumbersome with primary instrumentation, and the needle drivers were the first generation to do all these hand-sewn intracorporal anastomosis. This is the dissection of the bile duct. This is the going in front of the vena cava, the portal vein. This is, we had to make ski needles by ourselves from curved needles to do hand-sewn pancreaticojejunostomy, and this is the beginning of the hepaticojejunostomy hand-sewn as well. Now, Cuschieri, who was the other one on the other side of the Atlantic, who started distal pancreatectomy, we believe we did first case before him, but he said there was no place for laparoscopic Whipple at the time because there was concerns for an oncologic adequate operation. So it made a stop on the development more than 25 years ago on laparoscopic Whipple. If we look at the first 10 years, there were only 146 cases. And the type of procedure were mostly laparoscopic classic. I was doing pylorus preserving Whipple at the time, so that constituted about 1/5 of the cases. And the tumors were mostly ampullary, periampullary tumors, or chronic pancreatitis. The pancreatic adenocarcinoma was 1/3 of those cases. Complications were 16%, but leaks were half of those complications, pancreatic leak present. You can see the operative time and hospital stay was not any different than open surgery. So it was the reason for the slow development. Oncologically, I think it was correct. The margins were correct. The lymph nodes were correct. And the patient behaved the same as an open operation. Now, I had the fellow Michael Kendrick, who came at Mount Sinai and got trained from the Mayo Clinic at my program, and then went back to Mayo Clinic and started to do laparoscopic Whipple. And you can see the laparoscopic Whipple performed in the Mayo Clinic, a very conservative institution, was the takeoff for laparoscopic Whipple all around the world. And I visited the institution with Michael being now the chief of general surgery. So that was very interesting and very thankful of him for his invitation. The message is that lap Whipple is feasible. The post-op period seems to be the same, but if it has no complication, the post-op recovery is even better than open surgery, and there might be some advantage oncologically, but we need some more large randomized studies to prove this. In terms of distal pancreatectomy, I think there's a stamp of approval. A very important paper we published in Surgery in 1996 was our experience with distal pancreatectomy and islet cell tumors. This was the largest series at the time, and we used French position. There are many techniques we describe: opening the lesser sac, doing distal pancreatectomy from the tip, or stapling from the middle and then going towards the tip of the spleen. We also identified and made videos on splenic preserving versus non-splenic preservation. So this is, again, the first generation of harmonics that you can see. Older generations of staplers, they got better. This is a technique where we transected the pancreas and going to the tip of the spleen, taking all the branches and preserving the vessels. And of course, you can do the reverse in many ways. Here's the harmonic taking down the parenchyma, the thick one, which cannot accept the stapler, and then closing this with sutures on the pancreatic duct. Laparoscopic enucleation, we started with hooks at the very beginning, and then we went with the harmonic to take out some islet cells and putting glue in the area. So if we look at 10 years of the first distal pancreatectomy enucleation, there was only 176 cases published with no mortality. This is very important, no mortality. The pancreatic fistula were 17%. And what made the stamp of approval for laparoscopic distal pancreatectomy was this, again, American surgical presentation of 667 cases where the open was compared to laparoscopic, and it showed no difference in positive margins, no difference in operative time, difference in leak rate, but it showed the difference in blood loss, hospital stay, and complication dramatically reduced by laparoscopy. So in conclusion, left pancreatectomies and enucleation are the way to go. They cause less morbidity and shorter hospital stay, and I think that has been approved. Then the endoscopic parathyroidectomy, which we published in British Journal of Surgery in 1996, the first one being in the Cleveland Clinic by the end of 1995 on a very complex cases. And then eventually the neck surgery expanded to thyroid and other pathology. At the same time, when we did these first cases in IRCAD Strasbourg to make demonstration, Micoli and Henri were there, Henri from Marseille and Micoli from Pisa. Then they went back in their own institution 1 or 2 years later to do their own technique. Our instrumentation was developed at the time and made for this type of surgery. We shorter ports, very tiny mini instrumentation of 1.5, 2 millimeter. You can see these these that are even no longer available. And we had a 5 millimeter endoscope in the middle and just 1.7 millimeter instruments for dissection. These are among the first series, 64 parathyroidectomy at the time, mostly for single adenoma with operative time of 2 hours, which was twice or 3 times the time necessary to do this by an open technique. And as I said, Micoli came with a video-assisted technique. It requires at least 2 assistants to retract and hold the scope while the surgeon was dissecting, but it became easier and more popular. And the same with Henri in Marseille. This is my team in the mid-90s or end of 90s at Mount Sinai. Many of those fellows became leaders in their own field. Some you may recognize. And we started the program of the first endoscopic thyroidectomy in the United States and became very popular. We popularized needlescopic cervical surgery. This is the nerve, the recurrent nerve. He looks very huge by endoscopy. We make a lateral incision to extract lobes of the thyroid and make very cosmetic peeling procedures especially for women. Now, when those techniques were starting to be diffused and I was going around, Ogami from Japan saw us doing this and took a technique for the breast incision to do this kind of surgery. And of course, Takami from Japan doing an axilla technique very far to go to the neck. And this permitted the robotic to go from the axilla and eventually after that, the transoral technique. So to tell you how it goes into different evolution, our pig model permitted us to do carotid surgery in the neck, which never took off, but we were able to do suturing patches of Gore-Tex and doing all kinds of vessel surgery, esophagus surgery in the upper part, also in the neck. Here you can see a cricomyotomy being performed, and also cervical spine exposure and disc surgery in the neck. With that came physiologic studies of CO2 insufflated in the neck. We made boundaries of what was safe for human surgery, as well as intracranial pressure studies to make sure everything was good in the head while we were performing insufflating CO2 in the neck. And then lastly, the metabolic surgery development. Dr. Robino was a fellow that I had at the Cleveland Clinic and also at Mount Sinai. And we had protocols to look at hormones after Roux-en-Y gastric bypass, and also a protocol to look and study this in rats, which led to the development of duodenal bypass. At Mount Sinai, we developed a laparoscopic duodenal switch, and this was the first laparoscopic sleeve gastrectomy performed as part of the duodenal switch in July 1999. By serendipity, one of our patients could not get the intestinal part and got only the sleeve. And this led us to publish or present a first series of laparoscopic sleeve gastrectomy in 2000 for high-risk patients in 2 steps. And then the first presentation at an official meeting in SAGES 2002. So we know the rest is pretty much the history, that a sleeve is a removal of the left side of the stomach, leaving the lesser curve with a tube in place. that removes the fundus in body and lower half antrum. And now, in 2016 in the US, the statistics show that 3/4 of bariatric primary procedures are sleeve gastrectomy. So it has rapidly evolved. Randomized control trial with gastric bypass shows identical weight loss, remissions of diabetes are pretty equal, and hypertension, sleep apnea, not significant in this Swiss trial as much as the Finnish trial in the same JAMA randomized control trial publication of 2018 shows identical weight loss, not statistically different at 5 years. We think that this operation is good for Asian, low BMI for type 2 diabetes. This is a series from the China, shows that hemoglobin A1C is not any different than Roux in this series, and as well fasting blood glucose. So we think that sleeve gastrectomy has taken over the world as a first choice operation for diabetes as a metabolic operation. It's the most common metabolic operation right now in the world. And to move forward, I've made more research into duodenal switch operation, and we've made 4 consensus conferences. Duodenal switch is the best weight loss operation, but it's complex and has a lot of metabolic and complications. The resolution of type 2 diabetes has the highest ever. So how can we make this safe? That is really the question. And our 9-year data at Cornell of duodenal switch shows no diabetes 9 years later. And this is astounding when we think that we had 58% at the beginning of this series with the operation. So I went and did a series of sleeve gastrectomy with ileal transposition. We published this in 2005, and this was 2 years before De Paula in Brazil started to talk about this operation. We think that the interposition of ileum or the use of ileum is good for remission of type 2 diabetes because it changes some of the incretin. So we started in 2007 to do these duodenal ileal anastomosis. And this is what I call the duodenal bipartition, which is a side-to-side duodenal ileostomy. And I think that this operation will become probably one of the very common operations in the next decade. This can be added to a sleeve gastrectomy to complete the remission of type 2 diabetes. It's been very strong in animal data, and not only on weight, but on other. So the proper site of the ileum has to be determined, and will be part of the news in the future that you will hear from me. Because type 2 diabetes is more than 442 million worldwide that can benefit from this intervention. And it takes a long time to train a surgeon. So we need an intervention that is easy and fast for the treatment of our patients. So in conclusion, an idea has the right to be tested. We should get access to an animal lab to test those hypotheses. And I think it's important, what I've learned over 30 years is to get support from the colleagues and support from our boss so that we don't have problems when complications occur, because complication will occur in the process of innovation. And don't get discouraged in spite of negative comments, because I got a lot and I still get a lot today. And you have to be patient and persistent for establishing those findings. So thank you very much, and I apologize if I went over my time.
Thank you, Professor Michel. It was nice following your path to academic excellence all these years. There are a few questions, so maybe we have about 5 minutes or 10 minutes left. We can just request you to answer those. Maybe we would like to know what leads you to do such type of work, sort of innovative work, how it comes to you, and what are you thinking about the future? What are your dreams? Are there any more things which you feel I have yet to do?
Yeah, I think it comes from poor satisfaction of existing procedures. I think I feel that we should never be happy with what we're doing. We should always think, how can I improve this procedure for the care of my patients? How can I improve to have better outcome, lower complications? So when laparoscopy started, we tried to make those open operations into a laparoscopic because we saw the benefit for gallbladder. And I said, well, if it's benefit for gallbladder, it can be a benefit for all the other operations. So that's how the cycle of these procedures were going from open to laparoscopic. Now that we've obtained a plateau, even robotic is not really improving the outcome of our patients because robotic is laparoscopy. Okay, so it's the same holes, same about the same time, and so the outcome is going to be the same. But the next step is, in my opinion, flexible endoscopy. So how can we make some of the laparoscopic procedures by flexible endoscopy? And that's going to be the next decade or 2 or 3 movement, and miniaturize even more our instruments and do a combination of endo-laparoscopy or endoscopic full. That's going to be the next, and I still have ideas to make this goal and make it so that the patient can even do procedures that do not require general anesthetic, that can go home the same day or a few hours after the intervention, and lower the risk of our connections by lowering the bleeding and the leak.
Thank you. I must share with you our association, IAGES, is running regular fellowship courses in endoscopy, fellowship courses in advanced endoscopy, which was started when I was a president in 2018. And we already are running these where we train up the young surgeons in therapeutic endoscopy also. So it's a now surgeons have realized, and we have taken that initiative. Very, very, very well said. Very well said.
Thank you.
So, any suggestions, any tips would you like to give to the young surgeons about how should they develop their surgery? Any tips from you? Because there are many young postgraduate students in the program today.
Yeah, you have an idea, you have something that you think would be good for the advancements of surgery. Don't get discouraged. Write it down, get access to a lab, try it, even if you have negative comments. At the beginning, many people were telling you, oh, it's not going to work. It's not going to work. Why are you wasting your time? No, do it and persist, because that's, unless it's been really tested, you don't know. And you should, and it's surprising sometimes, even in the process of doing that, you find something new. And this is when you get into the development of new ideas and stuff.
Thank you very much. There's a last question, a small question. Someone has asked Dr. BML Khadaria. He's of course from Maligaon. He wants to know, do you feel that the cost of treatment has increased, and even with minimal surgery of adrenal, thyroid, pancreas, we are able to satisfy your patients and we are able to satisfy our patients? Your comments, please.
Yeah, a few years ago, I established my own surgical center, and as such, you become an administrator and you discover and you know really what the prices of surgery is. And you know the cost of every instrumentation, drugs, disposable, etc. And you know the total price of a procedure. And I can tell you that out of the 10 most common procedures, there was only one that did not make this cost adjustment, and that was inguinal hernia. But the rest was cost sound by using minimally invasive techniques, because there is a cost to complications, and you have to take this into account. I believe that because the hospital stay is reduced, the number of morbidity and mortality eventually by the shift from even laparoscopy to endoscopy will permit us to make a cost-effective thing. You know, if we're going to treat obesity and if we're going to treat type 2 diabetes, and there are millions of people to be treated, if we can only do 0.5% of the entire pie, it's going to take us 200 years to do it at the rate that we're doing it. So we need to change what we're doing to make it shorter, faster, a faster recovery, and treat more patients by the same number of surgeons that we have available. So it requires a big shift in mentality on how to see these diseases and new procedures.
Thank you very much. I think I should hand over to our President Raman Goyal for offering a formal thanks to you. And once again, thanks from me also, from all of us, for accepting our invitation and for sharing all your thoughts with us. Thanks.